हाँ?
ఒక 2 minutes ఆగి స్టార్ట్ చేసాలి 8:05 స్టార్ట్ చేసేది ఎవడొస్తాడు వచ్చి గుడ్ మార్నింగ్ సార్ రామారావు సార్
Good morning, sir.
పెద్ద క్లాస్ అయితే స్టార్ట్ చేసే విజయ్ లేట్ అవుతుంది
20 minutes పడుతుంది 20 minutes.
ఓకే అయితే ఒక 2-3 minutes 8:10 స్టార్ట్ చేసాం స్టార్ట్ చేసే విజయ్.
Good morning, friends and colleagues, seniors. Today, my topic is inadvertent perioperative hypothermia. Inadvertent perioperative hypothermia is defined as a core body temperature less than 36 degrees. It is a common consequence of anesthesia, which increases the morbidity and potentially increases the mortality. The core temperature of body is tightly controlled within the strict parameters of for effective function of many enzyme and transport mechanisms. Thermoregulation begins with input from the anatomically distinct heat and cold sensors that found in the peripherally in the skin and deep tissues and centrally in the spinal cord, brain and hypothalamus. The cold receptors are innervated by the A delta fibers, warm receptors by the C fibers. Both receptors communicate with the preoptic nucleus of the anterior hypothalamus via lateral spinothalamic tract or trigeminal nerve for the head and neck. In health, the posterior hypothalamus maintains a temperature set point between 36.7 and 37.1 degrees centigrade. Outside this interthreshold range, the hypothalamus initiates a homeostatic and behavioral mechanisms to return to the body normothermia. And this slide shows difference between difference of interthreshold range between an awake patient and anesthetized patients. The interthreshold range is widened in the anesthetized patients. They in this the thermoregulatory threshold in the awake anesthetized patients showing a widened interthreshold range after anesthesia. The interthreshold range describes the upper and lower limit of the core temperature between which no autonomic thermoregulatory effects are triggered. The core temperature above this range, body will initiate a cooling measures such as sweating and vasodilatation. A core temperature below this, vasoconstriction and shivering will commence. So anesthesia widens the interthreshold range. So core body temperature needs to be much lower than the in awake patient before the homeostatic warming methods are triggered. When cold effector mechanisms are the firstly vasoconstriction mediated by the alpha adrenergic receptors along with a behavioral changes such as using clothing and a shelter to keep warm. These are followed by the non-shivering thermogenesis and shivering. Non-shivering thermogenesis is mediated by the beta-3 adrenergic receptors that are found in the brown adipose tissue, which are more abundant in the infants, can therefore double the heat production in the neonates, but has a little significance in the adults. Brown adipose tissue contains an increased number of mitochondria that increase the lipid peroxidation to generate both ATP and heat. Non-shivering thermogenesis is a thus production of a metabolic heat without muscular activity. In contrast, shivering uses increased mechanical work to generate heat as a byproduct. This can increase the metabolic rate up to 6-fold more than the basal metabolic rate. When the core body temperature is higher than the interthreshold range, the hypothalamus triggers methods of cooling such as sweating and vasodilatation, along with appropriate behavioral changes such as shredding of layers of clothing and seeking shade. Thermoregulation. Here the heat balance describes the process of thermoregulation. The heat is produced by the metabolism and basal metabolic rate is independent of thermoregulatory feedback. 3/4 of the body heat is lost by the convection, radiation, conduction, and remaining quarter by the evaporation, predominantly in the respiratory tract. To maintain the normothermia, any lost heat must be regenerated internally with exercise and shivering, increasing the metabolic rate significantly to achieve this. Effect of anesthesia. So under general anesthesia, this control system is severely challenged. Firstly, the behavioral responses are completely abolished. Secondly, the interthreshold range is widened, 0.4 to 4 degrees centigrade. The homeostasis is compromised, and vasoconstriction and shivering methods can be reduced even further in elderly patients. This effect of inability of body to respond effectively to multiple causes of heat loss during surgery and anesthesia. This is triphasic pattern diagram showing heat loss during early hours and in the during surgery uh, of in case of epidural alone and general anesthesia and combined general anesthesia, epidural anesthesia. Here, three phases are noted: phase 1, phase 2, and phase 3. Phase 1 is the rapid phase due to redistribution, and the linear phase is heat loss during heat loss of by redistribution, evaporation, and conduction. Whereas phase 3 is the plateau phase. I will describe next slides. Redistribution phase, which is the first rapid decline in the temperature. So when vasodilatation leads to warm blood reaching the peripheries and cool blood reaching the from peripheries enter the core circulation. Here the redistribution hypothermia will occur. The vasodilatation is caused by both the direct effect of anesthetic agents and the indirect consequences of lowered constriction, vasoconstriction threshold. The linear phase, the heat loss exceeds the heat production from the metabolism. The metabolic rate is reduced by the 15 to 40% during general anesthesia. The reduced heat generated coupled with increased heat loss during anesthesia leads to negative heat balance, consequent hypothermia. This heat loss occurs by the following mechanisms. One is radiation. Though thermal radiation behaves like electromagnetic spectrum, it travels in the straight lines and can be reflected. Heat loss is proportional to the temperature difference between the core and environmental difference proportional to temperature difference between the core and environment temperature to the power of 4. Convection is heat loss by 30%. The transfer of heat to air by surrounding skin caused by the movement away from the heat source by molecules that have increased velocity because of transfer of heat energy. The heat loss is proportional to the velocity of air currents around the body and exacerbated in the operating theater by air currents and laminar flow. Evaporation by 25%. Heat loss is result of latent heat of vaporization. When heat from the body is used to turn into liquid into a gas, examples sweating and evaporation from the exposed body cavities, mucosal surface, and skin preparation, and the humidification of any dry respiratory gases. Conduction by 5% is caused by the transfer of heat from the warm object in direct contact with the cooler object. For example, use of a non-warmed IV fluids or contact with a cold theater table or mattress. Finally, the linear phase ends and the plateau phase begins, phase 3, which is largely because of the maximal vasoconstriction when an ongoing heat loss is balanced by the produced heat loss produced metabolically. Next slide is what is the regional anesthesia? Sorry. Regional anesthesia decreases the shivering and vasoconstriction threshold. Decreases shivering and vasoconstriction threshold below the level of block, probably because of a decreased afferent input from the peripheral thermal centers. Initial hypothermia occurs by redistribution of cooler peripheral blood to core because of vasodilatation induced by regional anesthesia. But vasoconstriction above the level of block can compensate some degree. The greatest risk of heat loss during combined regional and general anesthesia. Children, especially neonates, are particularly risk of IPH, perioperative hypothermia. Children lost more heat than the adults via conduction radiation because they have higher surface volume area to volume and less insulating subcutaneous tissue, adipose tissue, and children have an increased basal metabolic rate compared to adults. Infants have a immature hypothalamic thermoregulatory capacities and a high resting vagal tone, so less able to vasoconstrict. So furthermore, general anesthesia lowest threshold for vasoconstriction and other compensatory mechanisms, including non-shivering thermogenesis. Risk factors for the perioperative hypothermia. So ASA grade 2 to 5, if the grade increases, risk is more. Preoperative temperature less than 36 degrees Celsius. Preoperative warming is not possible because of clinical emergency. Undergoing a general and regional anesthesia, undergoing major and intermediate surgeries, at risk of cardiovascular complications, people having low basal metabolic index, BMI. What are the drug effects on core temperature? So tricyclic antidepressants will increase the core temperature. Antipsychotics will decrease the core temperature. Benzodiazepines decrease the core temperature. Anticholinergics oppose the temperature decrease from the benzodiazepines. The clonidine opioids are decreases the core temperature. Thermoregulation. Here metajola impairs the thermoregulatory control. Isoflurane and halothane impair thermoregulatory vasoconstriction in the infants and
హలో సార్ వాయిస్ వినపట్టలేదు సార్.
హలో శ్రీకాంత్, పవర్ తనకి వైఫై డిస్కనెక్ట్ అయినట్టుంది, మళ్ళీ కనెక్ట్ చేస్తున్నాడు. సారీ ఫర్ ది ప్రాబ్లం.
ఓకే
Hello. Hello.
విజయ్ చెప్పు.
Yeah, I'm sorry. Sorry for everyone. Sorry.
స్లైడ్ షేర్ చేయవా?
So the effect of drug on core temperature. This slide is thing over. Next slide. The midazolam impairs the thermoregulatory control. Isoflurane and halothane impair thermoregulatory vasoconstriction, and in infants and children, and propofol and volatile anesthetics inhibit non-shivering thermogenesis in the children. In neonates, risk factors for hypothermia are the younger age, length of the surgery is more than 30 minutes, and major surgery, and temperature is less than 36.5 degrees centigrade, and before the induction of anesthesia. The complications are the surgical site infections. So the hypothermia leads to decreased blood flow, decreased oxygen flux to the tissues, and oxygen tension is directly proportional to the oxidative neutrophil destruction of the bacteria for the 4 hours after the exposure. The hypothermia reduces superoxide radical production at any given oxygen tension, increases the surgical site infections. And effect on drug metabolism. Minimum molecular concentration of isoflurane is decreases by 5% per 1 degree centigrade, decrease in the core temperature. Tissue solubility of volatile anesthetics will increase with the hypothermia, causing delayed recovery. The hepatic metabolism is reduced, leading to the prolonged action of the propofol and opiates. Longer the action of neuromuscular blocker is caused by the reduced hepatic metabolism and a decreased rate of Hoffman degradation. Effect on coagulation reduces the enzyme capacity and diminishes the enzyme activity, leads to impaired platelet function, impaired coagulation cascade, and temperatures at the 30.5 have shown to increase the relative risk of transfusion by 22% increased. The cardiac complications, it mediated by the increased postoperative catecholamine concentration leads to increased arterial blood pressure, which increases the myocardial workload, and the ischemic cardiac events may also be compounded by increased skeletal muscle oxygen demand of any concomitant shivering. Postoperative pain makes the monitoring unreliable and independently increases the carbon dioxide production, catecholamine release, and cardiac output. And increased risk of surgical site infection caused by hypothermia is an established independent of increased risk of subcutaneous surgical site infection associated with perioperative blood transfusion. Maintenance of normothermia is a method of recommended by NICE for preventing surgical site infection. Normothermic patients have an increased collagen at wound site, faster wound healing. There is less evidence of IPH in pediatric patients, but many of the consequences are described are extrapolated into children. The norepinephrine release in response to hypothermia is increased in neonates and increased oxygen glucose uptake. This can cause metabolic acidosis with increased pulmonary vascular resistance, leads to right to left shunting, and decreased tissue perfusion and oxygen flux. These hypothermic children have a delayed recovery from the anesthesia, and postoperative respiratory depression can occur. This slide regards to intraoperative hyperthermia is rare, but body defenses are well preserved during general anesthesia, and infants and children at the risk of overheating. So pathological causes of active hyperthermia such as malignant hyperthermia, sepsis, blood in the cerebral ventricles, and adverse reactions to drug and blood transfusion should always be considered. Risk of overheating include increased peripheral blood flow, increased capillary permeability, edema, patients are more sweating, attempt to lose heat, hypothermia increases minimum alveolar concentration of inhaled anesthetic agents and reduces the duration of action of neuromuscular blockers. Frequent and continuous core temperature monitoring will detect hyperthermia. So treatment of active hypothermia depends upon the etiology, but may include antipyretic medications, active cooling, as well as treating the cause. Passive overheating is easily preventable and by vigilance and treated by removing the warming device or insulation. Temperature monitoring sites, the core temperature monitoring sites are the pulmonary artery, distal esophagus, tympanic membrane, nasopharynx, and intermediate sites not reliable during are the oral, rectal, bladder. These are intermediate sites, but not reliable during thermal disturbances. Skin surface is considerably lower than the core temperature, gives a reasonable reflection of core temperature, provided adequate adjustment for the core to skin gradient are made. This slide, what are the how to measures to take prevent hypothermia before surgery. So patients identify the patients who are at a risk of hypothermia and measures the core temperature before the surgery in the preoperative theater. So active pre-warming started if the patient has a less than 36 degrees centigrade of temperature. So patient should not be transferred to theater unless the core temperature is more than 36 degrees. So patient should be encouraged to walk to the theater if possible. And this increases the heat generation by metabolism. And during intraoperative, induction anesthesia should not be started until the patient core temperature more than 36 degrees and unless clinically urgent. So active warming is recommended for all high-risk patients regardless of age and length of the procedure, and for all patients with the total anesthesia time is more than 30 minutes. And the forced air warmer is recommended for this, and the temperature setting should be set at a maximum and then adjusted to maintain the patient temperature at least 36.5 degrees centigrade. And the theater ambient temperature should be more than 21 degrees centigrade, while the patient is exposed to reduce heat loss by convection and radiation. So ambient temperature can be reduced further for the staff comfort, and equipment is too cool. The surgical team should also be considered. And warm IV fluids, here the use of continuous fluid warmer incorporated into giving set, and pre-warmed fluids are effective if the within 30 minutes of removal of warming cabinet. Humidification of gases. Although only small amount of metabolically heat loss through this respiratory tract, the use of heat moisture exchanger filter for the alternative humidification device is recommended. And patients' temperature should be measured at least every 30 minutes and active warming titrated to effect. This is useful for the monitor both hypothermia and hyperthermia, and this includes patients having regional anesthesia technique. After surgery, the core temperature should be measured with observation in the PACU on admission every 15 minutes. And forced air warming should be continued if the patient are hypothermic with a warm blanket, offer comfort, but do not actively warm the patient. Patient should stay in the this ICU until the core temperature more than 36 degrees. Patient should be kept comfortably warm for 24 hours after surgery with duvet and blankets. The goal hypothermia, how to prevent, is pre-warming to reduce the temperature difference from periphery to core. So decreasing the amount of heat loss by redistribution after induction. Unless the patients are hypothermic, a short period of pre-warming should have no effect on their measured core temperature, as its peripheries are that are warmed. The updated NICE guideline is now recommend 30 minutes pre-warming as a way of minimizing the incidence of IPH in all patients. So there is evidence that even 10 minutes warming before induction of anesthesia decrease the incidence of IPH. And same slide. The forced air warming device is recommended method of active warming during surgery. It has been shown that is superior to resistive devices in preventing IPH. It is worth noting that there is a controversy surrounding the use of forced air warmers and potential for the disruption of laminar flow. There is mixed evidence that this perceived problem, but if the fluid air warmer is unsuitable, resistive heating mattress is recommended. So ideally, both the warming technologies should be used together in the patients with a group of high risk patients of hypothermia, and those having combined regional anesthesia where hypothermia loss is more. Cool IV fluids can have a clinically significant effect on core temperature. So 1 liter of a fluid at room temperature or 1 unit of blood at 4 degrees can decrease the core temperature by 0.25 degrees centigrade. So all fluid should be encouraged to therefore warmed before administration. Clear fluid stored in a warming cabinet at 39 degrees can be used for the low volume infusions. A prevention in IPH in children. Children should be kept warm before anesthesia with blankets and encouraged to walk theater if possible. Premature infants should be nursed in an incubator. And ambient temperature of operating theater should be kept high, especially for neonates. And active use of active warming, such as forced air warmer and fluid warmer, can be extrapolated to guidelines as for adults. So continuous temperature monitoring should be used for prevent hypothermia and burns. For obstetric patients, not specifically covered in NICE guidelines, but C-section is uncommon because patient mother is already in vasodilated state. So women should encourage to walk in the operating theater in the elective setting. Temperature measurement should be routine, and resistive heat mattress fluid warming, often used in obstetrics, should be mandatory if regional anesthesia surgery is longer than the 30 minutes. What are the treatment of forced anesthesia? Shivering. Shivering is a recognized consequence of both regional anesthesia. It can occur independently of temperature, but should never be treated independently of temperature. Pharmacological treatment works by the lowering the shivering threshold and lowers the metabolic heat production. So it would compound therefore it would compound hypothermia if not as addressed parallel. So most efficient way is warming the hypothermic patient with forced air warmer. Drugs used in to treat shivering are common is pethidine 25 milligrams, fentanyl, sufentanil, and buprenorphine, other opioids. Clonidine 150 micrograms, doxaprom 100 milligrams, ketanserin is other drug. And these are the same what I said before previous slides. Same in during intraoperative and preoperative postoperative measures. Summary: it is possible to avoid perioperative hypothermia if all types of potential heat loss is addressed. Short surgical cases are at risk of hypothermia. Pre-warming may be needed for high-risk patients if redistribution hypothermia is to be avoided. A local audit will dictate certain patients. Combined regional general anesthesia require two methods of intraoperative warming, such as induction mattress and forced air warming. Thank you, everyone, for kindly listening. And Hello. Hello.
Hello, yeah, Vijay, nice. Any questions, inputs, additional points?
Good morning, Srikanth. What are the sites of brown fat in children?
Sir, upper back,
Only one, other side.
nape of neck.
Infrascapular and supraadrenal.
Supra, sir.
Adrenal.
Supra.
Over.
Okay. Attendance.
Where are the temperature difference sensors present? After spinal, there is shivering. You are telling there is a difference of core and peripheral temperature. These are sensed by the receptors present where?
Since not getting your question, sir.
Huh?
Since receptors, you are asking receptors, sir? Or,
Yeah. They are sensed by receptors present in where? Hypothalamus or medulla oblongata or thalamus? Where?
anterior hypothalamus, sir.
Anterior hypothalamus is a temperature regulating center on to the difference is sensed by, I think it is in medulla. Anyway you search.
Okay.
So what is mild hypothermia? Is it protective for traumatic brain injuries?
Hypothermia is protective. Yes, sir. Traumatic brain injury. Decreases the oxygen consumption.
At what temperature you should maintain?
Mild is 34 to 35 degrees centigrade.
Previously, brain protection was used for protection hypothermia, but nowadays there is a controversy. Only mild hypothermia for severe traumatic brain injuries. It is protected. Whether how oxygen acts for shivering?
Increases the oxygen consumption will occur in. So how shivering means produces increase the heat. So heat loss can be
increased oxygen consumption because of
shivering.
So one of the treatment is you have to put oxygen.
Yes, sir. Yes.
You did not mention the drugs. Tramadol. We use routinely tramadol for.
Yes. Tramadol we routinely use.
Thank you.
Thank you, sir.
Good morning, Vijay.
Madam, good morning.
This is nice class, but I didn't see your slides. Slides are there or not? I don't know. But your class is very nice. And what are the complications you have to see in hypothermia? How you have to rewarm the patient. What are the steps you have to take it? During cardiac arrest, which temperature you want to go for a hypothermic technique?
Thank you, madam. Forced air warming is one technique that using forced air warming is one technique to increase the temperature of the patient. And for cardiac also, we use same technique. I thought, because I have no experience. So, what is the temperature means? Exact temperature I don't know, madam. Please tell me.
How much temperature you have to increase? That is 1 degree or
Much
Ac-
temperature.
actually I forgot everything. And in the CT we are using warmer, forced air warmer and blankets.
Okay.
If you want to increase the mild and moderate and severe temperature, means 35, 36 like this, the markings are there. You have to switch on the button, it will come. And bed sheet also is available. So you have to connect the connect ending point. So it will cover the whole neck to leg.
Okay.
That is one technique, and another is routinely using blanket. That means it look like a bed sheet.
Okay.
So water is circulating that area. So during the CPB, we are using that one regularly.
Okay.
Next, warmer fluids. That
Warming
means,
the fluids.
yeah. Whenever you are diagnosed the hypothermia, we have to use the warmer fluids. So sometimes what happened now, some people are using that saline bottle, keeping in a micro oven and take it and connect the patient like this. That is immediately. And another is a small sterilizer machine is there. That is boiling the water. You are keeping the normal saline bottles and taking, that is a one type of fluid warming, but that is for the surgical field only you are using. Routinely, immediate means you are keeping the micro oven 30 seconds or 15 seconds, and that is using. And in higher institutes, we have warmer machine. So all NS and RL and everything, you are keeping that machine. So it maintains the temperature. So whenever necessary, you can take the bottles and use. So that is useful in a polytrauma emergency, I mean casualty. So we are using that type. In my PDCC exam training period, I used like this.
Okay.
And now we are using transplant. No? So transplant cases, we have warmer fluids. Already that machine is already, already that device is there. So you can connect the saline, it all automatically warm and going. Same thing, blood also. Thank you.
Thank you.
Vijay, can you give blood transfusion if the patient is having a temperature of more than 100 degrees Fahrenheit?
You can give, sir, if the
Srikanth, Anuradha madam. In our institute, RK Hospital, they say that you decrease the temperature up to 100, then only. Is there any reason?
I think the blood-related transfusion reaction are normally patient already have infection. We don't know. Maybe that is the reason, sir.
I also don't know why. I want to know. Maybe exaggerated destruction
Because
of
we
organs.
cannot differentiate between, as madam said, blood. Is it blood-related hypothermia, or is the patient previously having fever? We cannot differentiate it, and we cannot differentiate the blood reaction. Maybe that's why we have to wait until the temperature gets down.
Another thing is, some people say don't give food while the blood is being transfused.
ఫుడ్ సంగతి తెలియదు కానీ అంటే హైపర్థర్మియా విల్ బి అసోసియేటెడ్ విత్ హీమోలైసిస్ కదా సార్.
Okay.
సో బేసిక్ గా అందుకనే ఎవరు high temperatures obviously will be associated with hemolysis. So more than 45 degrees centigrade actual ga anta that is very high temperature andi. Maybe it will correlate to 106 like that. There will be very rapid hydrolysis, hemolysis, sorry. But even 101, 102 will cause significant hemolysis. So itching blood low majority will be wasted, I think.
So wastage అందుకని temperature.
And damaged erythrocytes, all these things. So which is why we wait for core temperature to decrease mainly.
So rewarming means we have to increase the temperature slowly, 0.5 to 1 degree or 2 degrees per hour only, not immediately. But the hypothermia technique, you can decrease immediately. But in your rewarming means you have to maintain 1 degree centigrade per hour. Like.
Okay, Kiran, and anything to add or wind up?
I think in cardiac arrest is not going hypothermia technique. It's a normothermia only. I think 35, 36 are maintaining below. I mean 34 above only.
Okay, 34.
If I'm wrong, please correct it.
Actually, popular concept warm చేస్తా మేడం. సో అది మెయిన్ కాంట్రాడిక్ట్ చేయాలంతే. యూథెర్మియా ఆర్ మైల్డ్ హైపోథెర్మియా మీరు చెప్పినట్టుగా. బట్ మెజారిటీ లైక్ ఇన్ సెనారియోస్ మళ్ళీ we think like hypothermia may be the cause, and we actually try to increase the core temperature. But once the cardiac arrest happens, actually I think we have to cool the body or maintain a normal temperature rather than heating it and increasing the metabolic rate.
Yeah. Next, in cardiac cases, I mean aortic aneurysm and some cases we are going for circulatory arrest. That means we are going until 25 degrees. So before going to the 32 below 32 degrees, if the patient goes to heart rate VT followed by VF, and later it totally arrest. That means 25 degrees we have to maintain. So that time we are using the on the pump we are using thiopental and steroids and neuroprotective drugs we are using. And in the head region, we are keeping the ice bags. So totally we have to cover the head region. And next, after rewarming time, we are increasing the 30, 32. After that only we are removing the ice packs and slowly increase the temperature 35, 36. And later we are keeping the bed hugger.
Oh,
And one point is in post-op, when you are telling the sister you keep bed hugger, she will keep higher temperature. That means mild, moderate, and higher markings are there. So you tell the sister, please keep the bed hugger. What happened? No, that sister will keep the higher temperature, and after 1 hour she will tell patient have temperature. So that is the that reason also you have to remember. So always tell you can keep mild or moderate and slowly rema. And basically, I faced that problem, so that's why I'm telling.
You're right.
For brain protection, which is more powerful, pharmacological or hypothermic?
Powerful and sir.
Better, more power, more protection. it gives.
The brain protection means you have to use neurological drugs. Thiopental we are using 1 gram, and 1 gram to 2 grams also sometimes we will use.
అదే
And
మేడం దానికంటే అది బెటరా లేకపోతే హైపోథర్మిక్ విచ్ విల్ గివ్ బెటర్ ప్రొటెక్షన్?
Sir, ఇది two techniques, sir. Okati, we are doing the cases in cardiopulmonary bypass. So that time both we have to maintain. And the outside post-op ICU, that is totally different. According
Madam,
patient condition.
Madam,
And
brain metabolism
don't
is
go-
suppressed only to lesser extent by pentatone, while
Yes, sir.
hypothermia suppresses brain metabolism more. So
Yes, sir.
hypothermia is a better protection than pentatone because it reduces metabolism more.
Yes, sir.
పర్సంటేజ్ కూడా ఉంది, అది నాకు గుర్తులేదు. 35% అనుకుంటా.
ఓకే సార్, మెయిన్ ఒకటి గుర్తు పెట్టుకోవాల్సింది, వెన్ యూఆర్ నార్మోథర్మియా అండ్ హయ్యర్ you are doing giving the drugs, everything metabolized high metabolic rate, so you have to give more and more. And here what happened in a hypothermia technique, that way we are going circulatory errors 30 degrees below 25, that time we are using actually in a cardiopulmonary bypass we have to give the pharmacological drugs by hourly. But in hypothermia technique time, you have give drugs second hourly, because the metabolic rate, everything is reducing. So that's why we have to cut the drugs. Suppose 2 mg means you have to give 1 mg. Otherwise, second hourly you can give. Like this, we are using like a technique. We are using drugs like this. And when you are rewarming, you have to follow hourly or the 45 minutes, 30 minutes. What your protocol you are following, you can follow. But is mild is the very best, sir. Anything. If you are going moderate and severe, so hypothermia complications, coagulation affected, everything, see the complications and infection also.
Yes, ma'am.
okay, Vijay. Bye.
Okay. Bye. Bye. Bye.
Thank you, Vijay.
Thank you, madam. Thank you, everyone.
Thank you.
Thank you, Srikanth.
Thank you.
Thank you, Kiran.
Thank you.
Thank you, madam. Thank you, everyone.
Thank you to all.
Okay, Vijay. Bye.